So today I'm happy to welcome Dr. Alexis Eastman. Dr. Eastman is a clinical associate professor in the UW Division of Geriatrics. She completed all of her medical training here at UW and then was hired to stay. She currently serves as the Director of Clinical Operations for the UW Geriatrics Clinics, as Medical Director of Badger Prairie Health Care Center. And she's also the Integrated Block Leader for the Chronic and Preventive Care course at the SMPH. Her clinical practice focuses on primary care of older adults with additional clinics in consultative geriatrics, pre-operative evaluation, and rural outreach memory care. She has developed and continues to innovate models of care for older patients, including pre-operative risk, memory evaluation, telemedicine, and other forms of comprehensive geriatrics care. Please join me this morning in welcoming Dr. Eastman.
Awesome, thank you so much. That was very kind of you. And I've practiced this. I know I can share my screen. We're gonna hopefully continue to succeed in that practicing. Here we go, all right. If you cannot see it, gesticulate wildly and I will change something. So, again, super excited to be here today and talking about one of my favorite things, which is geriatric preoperative evaluation. So what is the real risk for our patients? And the first is the requisite slide on disclosures, of which I have none. One can only aspire to such things. And the requisite slide of the outline. We're going to do a whirlwind tour of my entire fellowship, which is aging physiology and frailty, and then talk about the preoperative evaluation and the concept of prehab and some practicalities. So this is actually a relatively short grand round. I know everyone always says that, but this is true because I love to leave lots of time for questions and discussion at the end. I think that's the most valuable part of all of this. So the next thing we always do is start with a case. So in this case, full disclosure, that is my grandmother and my aunt. They have given me permission to use their pictures. I have changed everything about their medical histories to protect them, but they said I can use their pictures with abandon. So grandma and aunt. And the other caveat is that I am obviously not a surgeon. I picked medical conditions that seem to me like they might require some sort of gynecological surgical intervention. So if I'm wrong, just please pretend along with me. So the case is twofold. You've got a 96-year-old female who's got atrial fibrillation on apixaban, a history of rectal cancer, status post-resection, some hypertension, some arthritis because she's 96, who has a new 12-centimeter complex ovarian cyst. And then you've got a 73-year-old female who's got rheumatoid arthritis on hydroxychloroquine, a history of esophageal stricture, status post-dilation ×3, depression, who's underweight, who now has a high-risk stage 1 endometrial cancer of some type. And then the question before all of you, these are sort of rhetorical questions, but think about in your head, is which one do you take to surgery? And how do you know who you're going to take and what the risk is going to be? So what happens with aging? Well, as many of my patients have told me over the years, as you get older, everything gets stiffer, saggier, and leakier. And that's a good general rule of thumb when you're talking about normal aging physiology. But let's break it down, kind of a more surgical standpoint, a little bit more detail. So what happens to the aging heart? So solid organs in general follow what we in geriatrics like to call the 10% rule. So after about the age of 60, you lose about 10% of your blood flow to your solid organs per decade. And that equates to about 10% of your cells in the solid organs. And so in the heart, that equates to 10% loss per decade after 60 of your myocytes. When that happens, you have conduction pathway fibrosis because nature abhors a vacuum. So if you lose a muscle cell, you're going to replace it with something else, in this case, fibrosis. And that causes a decrease in ventricular compliance. So people get diastolic dysfunction as a part of normal aging. You become more preload dependent. Other things that change in terms of the nerves is when you're losing not just muscle cells, but you're also losing nerves, and you're losing nerves in other parts of the body, including the carotid bodies and other places. So your beta adrenergic response decreases. So altogether, what does that do? Well, it increases your risk of arrhythmias. This is part of the reason why atrial fibrillation is so much more common in older patients. You have increased diastolic dysfunction. But as you might imagine, the systolic function is usually pretty okay because a fibrotic heart is still going to push, right? It's going to rebound pretty well. It's just not going to relax very well. Because of the change in beta adrenergic tone, you have an increase in orthostasis. All of that adds up to volume issues. So minor hypovolemia in older patients is a bad thing. It can become much more problematic than it would be for us. And so even though we are often erring on the side of running older people, quote unquote, dry, because we're worried about their heart function, the real truth of it is that if we make them too dry, it's a really serious problem with hypotension in the operating room and afterwards. So let's talk about the aging lung. So the aging lung has the same problem, right? Stiffer, saggier, and leakier. So the muscles surrounding the lung and the lung itself have a decrease in compliance, right? So they're not going to be as stretchy as they were before, and they're not going to bounce back as much as they were before. So decreased elasticity and compliance. This leads to a decrease in the maximum expiratory force, also a decrease in the maximum inspiratory force, a decrease in your FVC and your FEV1, if you're remembering your PFT knowledge. And when you have a decrease in lung elasticity, it means your small airways are much more likely to collapse. The change in blood flow leads to an increase in VQ mismatch. All of this adds up to a decrease in the PaO2, although the PaCO2 is okay. And of course, we often are taking patients to surgery who have a history of PaCO2 elevating diseases such as COPD. You also have a decreased cough. So both the esophagus and the trachea, all of these things have more difficulty clearing secretions and moving in general. So the cough strength goes down with age. So what does that equate to? An increase in atelectasis, an increase in aspiration, and an increase in pneumonia. Those rates go way up the older you get. On top of that, there's things that happen that put you at an even further increased risk of aspiration after a surgical event. So COPD, as we talked about, what's known as a class 2 ASA airway, which is a picture there, which is mostly just from the illustration, a super dangly uvula. But in truth, it's really a soft palate that kind of falls back into the throat more easily. Sleep apnea, which makes sense, pulmonary hypertension, and current smoking. Contrary to popular belief, obesity is actually not a risk for post-operative pneumonia. You'd think it would be, but it's not. Type 2 diabetes isn't, and well-controlled asthma is not. Uncontrolled asthma, yes. Well-controlled asthma, not. So when we're talking about the next solid organ on my list, which is the kidneys, not quite as cute an illustration, but bear with me. What happens to the aging kidney? Well, they still follow the 10% rule. So you lose 10% of your nephrons after the age of 60 every decade. Interestingly enough, it's the long nephrons that die first because they're already going into the most hypoxic environments in the outer cortex. So it doesn't take much relative hypoxia to knock those guys out. So the longer and ostensibly better nephrons are dying off faster than the short ones. This is the decrease in renal blood flow we were talking about that leads to the decrease in nephrons. So you have a decrease in the GFR and the creatinine clearance. However, that doesn't always show up on the labs because kidneys work really hard and those last remaining nephrons will be working their little nephrons off just to keep the creatinine normal. So the GFR is down, the creatinine clearance is down, the creatinine may be normal. To add insult to injury, the hypothalamus controls your sense of thirst, and this is a brain-kidney connection. So older people are less thirsty. So the younger people in the crowd are OB-GYN residents. You guys are going to start feeling dehydrated when you're about 9% dehydrated. An older person, someone in their 80s, is not going to feel thirsty until they're about 20% down, give or take. That's pretty dehydrated. I don't have to tell you about the increase in urinary tract dysfunction of older adults of any type, but this all adds up to the fact that everybody over the age of 80 effectively has CKD3, even if their labs are normal. everybody is at an increased risk of an AKI, usually pre-renal, right? The most common cause of an AKI in an older hospitalized patient is a pre-renal AKI, often induced by us when we have them sit in an emergency room for hours on end without water or IV fluids. The drug-induced kidney injury is not really the CT contrast, right? We talk a lot about contrast, but that contrast bolus is time limited and the newer contrast agents are much less nephrotoxic. So the bigger concerns for a drug-induced renal injury are diuretics or medications that directly cause ATN, things like penicillins or anti-inflammatories. So that's something to keep in mind because AKIs are often very, very avoidable. So the aging immune system, I am not going to go through this in great detail because it's painful and they come up with new interleukins every day and I can't keep track of them. However, it is important to know that in the aging immune system, it gets a lot slower and it becomes dysregulated. So as you might imagine, as you get older, you have fewer naive T cells because you're older. They've seen a lot. You've seen a lot. Your T cells have seen a lot. So you've got a lot of memory T cells. You have a decrease in antibody production that goes along with having lots of memory cells, but not a lot of new things to overreact to. You have decreased signaling and decreased chemotaxis. So even when you do get an infection, it takes longer and it's slower for your cells to get to the site of infection to take care of it. You have a decrease in, and here's a couple of interleukins and CDs, but a decrease in IL-2 and CD28 and an increase in inflammatory signals. So the immune system has a tendency to promote inflammation without fighting infection, and then have a really hard time turning that signal off. The other thing that happens is your hypothalamus again, the aging hypothalamus is a problem. The hypothalamus is in charge of your core body temperature. So older people, the stereotype of older people wearing sweaters is founded in some vague science, which is that they are actually operating at a lower core body temperature. So what does that mean for us? Well, the thing to keep in mind is that a geriatric fever, someone in their 80s, is 99.2. It's not 100.3. Ideally, it's 2 degrees above your baseline temperature if you know it, which most people don't. Some nursing home patients we do, but in general, we don't know anyone's core body temperature. But 99.2 in a frail older person is absolutely a fever. You'll see chronic elevations in ESR, CRP, and D-dimer. There are age adjustments for all of those. And the other thing that's really important to know is that the leukocytosis of an infection, a post-operative infection, is delayed, maybe delayed by up to a day. So they may have an infection long before you see a bump in their CDC. So that's important to keep track of. From another functional standpoint, we'll move on to muscles. This is a fairly depressing slide, so I'm sorry in advance. So you lose muscles after the age of 30, right? It's all downhill after 30. I think from a biochemical standpoint, a Krebs cycle standpoint, you peak at 12. So we're all over the hill. But from a muscle standpoint, you peak at 30. And you lose 1% per year of your muscle after the age of 30, which is a chunk of change. Now, we know from good studies that if you work out, you can build muscle. You will keep losing it at 1% per year, but you can kind of bump that curve to the right. And from the data we have, we know that if you work out 4 or 5 days a week of your adult life, moderate exercise with some strength training, then by the time you're 85, you can be about as buff as a lazy 30-year-old. So there's your lifetime goal, lazy 30-year-old. Because you're losing muscle, you're also losing mitochondria. You also have slowed repair. Everything slows down, including the repair of muscles. And again, as I said, nature abhors a vacuum. So instead of fibrosis in this case, your muscle decreases and you refill it with fat. And so you lose muscle efficiency. So you're losing muscle mass, you're losing muscle efficiency. This is part of the reason that older people fall more. And when it becomes a chronic and debilitating issue, we call it sarcopenia. So if you've heard about sarcopenia, that's what that is. It's sort of an end stage muscle loss, strength loss that leads to frailty. This is important at all ages, right? We can have patients who are younger who have a lot of fat mass and not a lot of muscle mass. This is the same process for them physiologically speaking. So from a muscle age, they're geriatric, even though their physical age may be quite young. And the same thing happens with the skin. So in the skin, you have a decrease in collagen production. I think we all know that. That's where wrinkles come from. You also have a decrease in fibroblasts. Again, the repair cells decrease in number. You have decreased mucosal secretions, so decreased saliva, decreased mucus. Every secretion decreases with age. And that leads to a poor wound healing, an increase in dehiscence, and dissolvable suture may not dissolve. This is particularly problematic in ENT surgeries, but it can be problematic elsewhere. Dissolvable sutures can stick around for months and months and months, which can be a problem for some people. One of the things I care about is the aging brain. From a surgical standpoint, however, the most important part is not the brain itself, but that funky orange line I've drawn around this stock picture of the brain, which is the blood-brain barrier. The older you get, the leakier the blood-brain barrier gets. This is great if you're giving someone ceftriaxone and you're treating them for meningitis, right? Wonderful. It's going to go right into the brain and take out that sucker that's causing the meningitis. Not so hot if you're giving someone a medication that goes into their brain. So more meds leak in, you have more cognitive side effects. So what are the problem meds? Well, the problem meds are things that we like to use in the hospital. Benzodiazepines, tramadol, propofol, inhaled anesthetics, lidocaine and all of the other canes, all of the seizure meds, all of the dopaminergics, all the antipsychotics, and all of the anticholinergics, right? From Benadryl all the way to oxybutynin. They all get into the brain. They all cause more cognitive side effects. So everything other than the anticholinergics you can see are all supposed to get into the brain on some level. They do that so much more in an older person. And the other thing we just talked about was the fact that muscle mass decreases. And as muscle mass decreases, fat mass increases. And when your fat mass increases, then fat-soluble medications stick around a lot longer. And the brain is mostly fat. So most of our psychotropic medications are very, very fat-soluble. And so the half-life of most of these medications is 3 times longer. So I'm usually telling my students, if I give one of them a Valium, they're going to have a nice day for maybe 8-10 hours. If I give my grandmother the same Valium, 96 hours later, it's going to finally be wearing off. Right? So as you can see, that would be a problem. And if we keep giving them at scheduled doses, they build up and they build up and they build up. And then it takes days and days and days to clear those medications out. And that is one of the main causes of post-operative delirium, among the many other causes. Well, what other things happen in delirium? Well, risk factors include cognitive impairment, comorbidities, frailty, immobilization, sensory impairment, like not having your glasses or your hearing aids, or having weird light shifts, which happens all the time, and or polypharmacy, which we just talked about. So these are all things for increasing your risk of post-operative delirium. As you might imagine, they're the same risk factors as every other poor post-operative outcome. So fortunately, that makes it an easy list. We just have to think about these things and know that post-operatively, all things might go bad in this situation. I'm going to step it back a little bit and look at kind of an underlying principle, because I think we've talked about the physiology of individual organs. But in the big picture setting, a lot of people ask me, well, is that person frail or not, right? And what's that mechanism there, right? What does that mean? And the concept behind that, which is something we really like in geriatrics, is a term called homeostenosis. So we all know homeostasis, right? Homeostasis is the tendency towards a relatively stable equilibrium between interdependent elements maintained by physiologic processes. Yeah. It is the attempt of the body to maintain internal constancy, right? It's your bounce back mechanism. When something happens to you, can you bounce back? And it requires fully functional compensatory mechanisms. So what is homeostenosis then? It's the exact opposite, right? As you age, you have a decreased ability to maintain homeostasis. You cannot retain and regain internal constancy in the face of challenges, whether that's an internal challenge like an infection or an external challenge like a motor vehicle accident. It is the end result of something we call decreased functional reserve, right? Functional reserve is your capacity to bounce back. It is how much biochemical activity you have to fulfill your physiologic role and therefore cope with any sort of insult and injury. That's a lot of words, so there's a fun picture. So if we say that your physiologic limit, your functional reserve is up here when you're young and down here when you're old, you can see the red arrow is a stress. So the stress happens and you're 20, you've got lots of functional reserve, right? So you just bounce back, you return to green, it's all lovely. If you're 80, same stressor, much less functional reserve, you can't cope. You end up in the hospital, you end up in the nursing home, you have a disease that's incurable, you die. Right? That's the end stage homeostenosis. So homeostenosis is actually normal aging, right? And here are these things that feed into it, things that we've sort of talked about with these organ systems, the loss of structural complexity of organs, a higher baseline inflammation, leading to an increased variability of physiologic responses. We talked a little bit about the loss of negative feedback. You can't turn the signal off. You accumulate stressors as you age on every single level, right? Biochemically on up. And you have an altered stress response. That's homeostenosis. So homeostenosis is normal, but it is a risk factor for frailty, right? And that's a kind of an odd concept. Everybody's homeostenotic, not everybody is frail. So what's frailty? So frailty is this kind of nebulous place, a state of increased vulnerability to poor resolution of homeostasis after a stress, which increases the risk of adverse outcomes, falls, delirium, disability. It's end stage homeostenosis, right? It's when your bounce back is so impaired that the least little thing is going to knock you off the ledge and you can't recover from acute illnesses. You are chronically weak, you're chronically falling, you have chronic impairments in physical function, you're losing weight without trying, without having cancer, you have low energy or exhaustion, and you really have low physical activity. So that's nice, that's a nice set of defining features. How does it happen? Again, I'm not gonna make you walk through my entire fellowship, there it is. You can look it up in textbooks. It's lots and lots of things. It's a very complex system. How do you know if someone's frail? Well, this is when everyone always says to me, I know it when I see it, right? But if you're looking at my grandmother and my aunt, which one of them is frail? Is it one? Is it the other? Is it both? Whose walker is that in the background? We don't actually know. It's a little hard to tell. So what do we do when we're trying to do that? Practically speaking, and scientifically speaking, there's probably about, I don't know, 100 frailty screening tools out there. Some are more useful than others. The one we use the most, which is the best, the most well validated, is the Freed index. The Freed index is positive for frailty if you are losing more than 5% of your body weight unintentionally in the last year, if you have subjective exhaustion, which could be everyone during the pandemic, if you're feeling weak as manifested by decreased grip strength on a dynamometer, if you have a slow walking speed, which I've underlined because that's probably the most important part, and if you have decreased physical activity. So that's a little hard to get to. We've broken it down to a FRAIL scale, which you can ask patients about. If you skip the middle one, which is good because then it can be a sort of telephone screener if you need it to be. It's a score of 0 to 5. There's the unintentional weight loss again, self-reported exhaustion. Because intermediate frailty is only 2 to 3 points, you could either do the grip strength or not, depending how you need to do the screening. Slowed walking speed, again, which can be measured in many ways, and low physical activity, which is to say rarely undertaking a short walk. And 0 is a perfectly healthy patient, 5 is an extremely frail patient, and 2 to 3 is intermediate. So that's kind of a good rule of thumb. So why did I underline slow walking speed? Well, this is one of my favorite slides of all time, which I flagrantly poached from Bjorn Bering, who was a faculty here several years ago, lovely guy. and is a sarcopenia researcher. But there was a meta-analysis done probably 15 years ago now that looked at 9 cohort studies, roughly 35,000 adults over the age of 65, roughly half of whom were women, and followed up on 17,500 deaths over 6 to 21 years. And they studied the effect of usual walking speed on mortality. So you can see it's divided between men and women, and the median survival and gait speed and age. And if you look at it, it's amazing. If at age 65, you can walk 1.3 meters per second, you on average will live 12 to 17 years longer than someone who can only walk 0.5 meters per second. So speed walking saves lives. If you're 80, it's still a 6 to 7 year difference in terms of mortality. It's kind of amazing. So it doesn't matter if you have an assistive device. If you're a speed walker with a walker, you are still going to live longer than a slow walker with a walker. What do we do with that in clinic? Well, that's where the timed up and go comes in. So the tug is a timed walk. The patient stands from a chair, walks 10 feet, turns around, walks back, sits down. If it takes more than 12 to 13 seconds, they're frail, done. It's easy. It has excellent inter-rater reliability. That's too many L's. It correlates to gait speed, functional outcomes, and it can be tracked over time. So that's a lovely thing, down and dirty, to do in the clinics. So I'm going to just arbitrarily choose one of the 2 women in that photo, which is grandma, and say, what's her pre-op? So you may know her medical history. You see her in clinic. She's the 96-year-old with this new 12-centimeter complex ovarian cyst. She has hypertension on lisinopril, atrial fibrillation on Eliquis and metoprolol, osteoarthritis on Tylenol, and she ambulates with a 2-wheeled walker, has this history of rectal cancer, status post-resection 10 years ago, did very well. Well, that's great. What else do you really want to know? Because we've talked through all this physiology. You don't know if she's frail. You don't know what's going on with all of her organ systems. So you don't really know, can she undergo surgery or should she undergo surgery, right? So we'll pull in all of those pictures, right? And so we start to say, well, what other things do we need to know that are going to tell us what is her actual risk of poor post-operative outcomes? We don't know her cognition. That's a risk for delirium. We don't know her mood, also a delirium risk. We have no idea what her meds are other than what they've told us. Hopefully that's all of them. We don't know her nutritional status. We don't know how she's going to heal. We don't know her substance or tobacco use. We don't know her comorbidities other than what's listed, which hopefully that's all of them. We don't really know her functional status outside the 2-wheeled walker. And we have no idea how useful my aunt is at home, right? So conveniently, this list of things that really need to be done on a pre-op screening are also what the ACS and AGS NISQIP GERI preoperative recommendations are. So in addition to your quote unquote standard medical evaluation, which is sort of nebulous also, you need to look at cognition, moods, meds, comorbidities, tobacco and alcohol, function, nutrition, and you need to also counsel the patient and the family on what it's like in the hospital. What's going to happen after the hospital? Do they have an HCPOA on file in their other advanced care planning? Are they DNR, DNI? Might be nice to know before you get to the OR. And then any sort of additional risk stratification as needed. That's kind of nebulous too. So there's lots of tools out there. Tools equals standardization. Standardization equals a more quantified risk. And what you really want is you want to know what the actual risk is. So for cognition, we have multiple tools. There's the mini mental status exam and the St. Louis University mental status exam and the Montreal cognitive assessment. Of those 3, the SLUMS will always be free because it was created federally. The other 2 are proprietary. So the free one is SLUMS. That's why we use it the most. For mood, you've got a PHQ-9 or a geriatric depression screen. For frailty, I'm a big fan of that timed up and go because it takes ideally less than 13 seconds. The Freed scale or the FRAIL scale, depending on how scientific you want to be. For function, the tools that are embedded in EPIC are both the Lawton and the CATS. These are good tools for activities of daily living and instrumental activities of daily living. For nutrition, there's actually a mini nutritional assessment short form. Yes, it was originally invented by Nestle. It has been validated very well since then, and it's a great tool, and it's short. And for pulm, there aren't a lot of screening tools outside of the stop bang, but screening for sleep apnea does help. And then the one we all know is the revised cardiac risk index, which is a very limited utility, but it is important to do. And into all of that, though, is the, not only, can you quantify that risk, but can she quantify her risk? Can she consent to this surgery? And how do you know? So what are the components of a capacity evaluation? Well, in order to know if someone has the capacity to consent for surgery, they have to be able to demonstrate understanding of the medical condition and the likely outcomes. They can't just say they understand you. They have to be able to tell you. They have to be able to understand the procedure risks and benefits. Again, it's not a nod and smile thing. A lot of my patients nod and smile at me all the time. And that's not because I'm telling them stupid jokes, although it usually is. It's also because they're not really understanding, but they want to be polite about it. You have to be able to communicate a choice in some way, verbally, in written terms, through a Ouija board, with interpretive dance. It doesn't really matter. You have to be able to communicate your choice. And you have to be able to engage in a rational discussion about the treatment options. You don't have to agree, right? That agreeing with whatever the doctor recommends is not part of capacity, but you have to be able to present a rational argument for why you disagree if you do. So that's the important part about capacity. And that's something we often miss in the consent process is really getting past the nod and smile and getting to, do they really know what I'm proposing I want to do to them? So let's go back to grandma and we'll say, what's her pre-op? Well, so using a couple of these validated tools, we say grandma has a St. Louis University mental status score 17 out of 30, which is decreased. Normal is 26. She's not depressed. Her PHQ-9 is 0. She doesn't smoke, doesn't drink. She's independent for her activities of daily living, which is the basics, such as like getting dressed or going to the bathroom or transferring with her walker, things like that. But her kids help with her instrumental activities of daily living now. So the finances and driving and shopping and making meals. And she uses a 2-wheeled walker. She's had 4 falls in the past year, mostly due to impulse control, getting in and out of the car. And her timed up and go is 22 seconds, so 10 seconds longer than our cutoff for frailty. And if we do an over-the-phone FRAIL score, she gets a 4, so she's considered frail. Her mini nutritional assessment short form is 9, so she's at risk of malnutrition, but she's not actually malnourished, but she has dropped 10 pounds in the last year. She lives with her daughter, who has her own health issues, as we discussed, who's of limited assistance. But then she tells you straight up, I would rather die than go to a nursing home. So it's an important piece of care management, because if you're going to take her to the operating room, nursing home is always on the table for rehab, right? But she'd rather die than go there. And her power of attorney is, this annoying out-of-state granddaughter geriatrician, fortunately not activated, right? So she is officially frail, right? She's got cognitive impairment, functional impairment, lots of things going on. She's at risk of malnutrition. So she's at much higher risk of poor post-operative outcomes than you would initially think necessarily by just knowing she's got well-controlled hypertension and atrial fibrillation. And so a much more in-depth look. Well, so then what, right? You got, can she undergo surgery and should she be consented for surgery? These 2 questions. So I am often asked, is this person cleared for surgery, right? That is a question I am often getting in my preoperative clinic. And I think it's really important to take a moment to know that what we can do is quantify someone's risk. We can give you a really good sense of how risky is this surgery that you're about to take someone into. But no pre-op can tell you the should answer, right? Because I can tell you how risky it is, and only you know how much risk you're willing to take on, right? That's a very individual decision. So if anyone tells you someone's cleared for surgery, they're lying to you. They can tell you that there is a certain amount of risk and that no additional studies will help you determine that risk, but they can't tell you whether or not someone should go to surgery. Now, there are occasions where I think someone should absolutely not go to surgery, where I think their risk is just insanely high, but it's always my opinion, right? Always my opinion. So moving from that, I think the big question for all of us who are involved in preoperative research is, can we change that, right? Can we change the needle on a frail person and make them less frail and make them have better post-operative outcomes? Can we prehab an old person so that they get through surgery better? And when we're looking at that, there's a lot of things we can't fix, right? I can't really fix someone's underlying peripheral vascular disease. I can't fix their history of coronary artery disease or 3 strokes or all of those things, and barring a few things, I can medically optimize them. But I can fix a lot of their strength or their nutrition or their horrible polypharmacy or their 3-pack-a-day smoking habit or their functional supports through resources. And so if you look at kind of the tower of the prehab interventions as they stand now, there's a lot of screening down at the bottom of that pyramid. And then there's targeted interventions based on screening, with at the very top kind of this high intensity intervention of a very serious prehab. So we're going to talk a little bit about this. The evidence. What is the evidence that prehabilitation helps? Well, I'm a big fan of exercise. There's this great study out of the Journal of Scandinavian Sports Medicine or something from 1980, whatever, saying exercise as treatment for, and then it lists off like 100 things, right? It's this great meta-analysis. And the answer is true. Exercise is good for everything and has no side effects. If you've been paying attention to the data coming out of the Alzheimer's trials, exercise, moderate aerobic exercise most days of the week, your adult life, will decrease your risk of developing Alzheimer's by about 40%. Not shabby. Better than any pill I've got anyway. But what does it do about your post-operative outcomes? Well, there's a ton of studies on prehab exercise, and most of them show that prehab exercise decreases post-op complications. Now, there's a lot of really mixed quality studies out there, and the interventions are all over the map, right? Some interventions are HIIT, like old people CrossFit. Some are walking. Some are isometrics, some are bicycles. There's all sorts of different studies out there. And some of them focus on strength and say, well, if you have more muscle, you'll heal better. Some of them focus on aerobic capacity that say, well, if you've got more lung power, you'll not have pneumonia. In general, we know it decreases post-operative complications, but we don't know exactly which exercise is best or which effect is best, the wound healing versus the aerobic capacity. When you're looking at other areas of geriatric data, we know that aerobic exercise and strength training decreases falls. Just 6 weeks of strength training will decrease falls by 50%. That's huge, especially if people are falling out of bed after their operation. We also know that there is medium to high quality evidence that exercise decreases frailty overall. Frailty, as I said, is this nebulous kind of hard concept to wrap our heads around. So most of that exercise intervention is inside of a multimodal nutritional home support sort of intervention. So it's hard to tease out exactly how much role exercise plays, but it certainly doesn't hurt, right? Well, what about nutrition? So this is, I'm going to flip what a lot of us learned in medical school on its head. We were all taught in medical school that old people kidneys, which are delicate little things, which is true. They are delicate little things. They're very prone to dehydration related injury. But what they're not prone to is struggling with protein, right? That's mythologic. And older people don't metabolize protein as well as younger people. So it'll go through their gut unmetabolized. And so healthy older people actually probably need 1 to 1.2 grams per kilogram per day. And a frail elderly person probably needs more, 1.2 to 1.5 grams per kilogram per day. So for the average 70 kilogram textbook patient, that's 84 to 105 grams of protein a day. That's a lot of protein. That's like bodybuilding level of protein. So normal adults, quote unquote, middle-aged adults, we say usually 0.8 grams per kilogram per day, or 56 grams per day. So you're really talking that older patients need a lot more protein, but they have to have it with exercise and time. Otherwise, you don't absorb it. You have to utilize the protein to do something with it. Otherwise, it just becomes fat like everything else, right? You have to build your muscle. So that's an interesting turn on its head. And there's good data supporting the malnutrition and the malabsorption of protein in the elderly. So more protein for them. So what does that look like? Well, I pulled that picture out because at some point in time, I learned that the former President Nixon loved ketchup on cottage cheese, which I think is like, personally, I find that to be gross, but it is high in protein. So there's my picture of ketchup on cottage cheese for you. How do you do this? Well, I send a lot of people to nutritionists, right, and say, what is a high protein diet for this person? How do I feed them a high protein diet? You send them online, all the sources, they'll end up with ketchup on cottage cheese. People are always drinking Ensure and Boost. I have a love-hate relationship with them. And this is why. Regular Ensure, regular Boost, they're actually only 10 grams of protein per serving, which is not that much for stuff with a lot of filler, a lot of odd flavors. And both of them have high protein versions, which is 20 grams of protein per serving. And so they're fine. They're a good nutritional supplement. If you need someone who just needs calories and they like the taste of Ensure and Boost, then great, but they're not cheap, even if you get them at Sam's Club or Costco or whatever. So other protein shakes may be better. They're often more expensive. So if you're talking to your patients, I strongly recommend unflavored protein powder in a regular milkshake. If you look at your regular fast food milkshake is usually about 500 calories. You add about 2 tablespoons of protein powder to it, that's 20 grams of protein and 500 calories. If you do one of those a day, that's 1 pound a week, roughly in terms of caloric intake. Not a bad supplement for your pre-operative patient. And then we get to safe prescribing. And as I mentioned, everything that's psychotropic and everything that's anticholinergic goes into the brain and causes havoc. There are burden scores out there. You can know how anticholinergic something is. So there are better offenders and worse offenders. So not to call out these, but to call out these, oxybutynin is very anticholinergic, right? Some people swear by their oxybutynin. I can't fault them. If they tolerate it, they tolerate it, but it's very anticholinergic. Trospium, a lot less. Everybody else, somewhere in the middle, right? But you can calculate that out online. Lots of medications are deliriogenic, right? Anything that gets into the brain in general will cause delirium postoperatively. That's your benzos, that's your gabapentin, that's your zolpidem, that's your zolpidem and friends, all the Z drugs, and all psychotropics. And then I put this in all capitals. Please avoid tramadol in the inpatient setting. If you look at the large-scale European trials of tramadol versus codeine, tramadol versus morphine, tramadol versus anything, morphine is safer than tramadol as a postoperative pain medication. Tramadol increases postoperative mortality and postoperative morbidity, lots of delirium because it hits too many receptors. It's easier to prescribe, but opiates are actually safer than tramadol in the postoperative setting. So please avoid tramadol postoperatively. And then you have to think about the potential for withdrawal, right? If someone is on opiates or benzodiazepines at baseline or gabapentin or SSRIs, you can't stop those abruptly for a surgery. People will withdraw. So that's something to keep in mind. Usual holds for surgery, supplements, blood thinners, ACE inhibitors, etc. Ask your pharmacist. I am always calling the pharmacist, right? I'm always just saying, Louisa, what's going on with this med list? Help me out here, right? That's what we have pharmacists for. They're lovely people. Substances. Putting this up here to remind people that many of my patients are the same age as Keith Richards, who is decidedly geriatric. So substance use is real. Please screen your patients for it. Tobacco, what's the data? So even a few weeks of tobacco cessation decreases postoperative complications, improves wound healing, decreases dehiscence, doesn't take long. The nice thing is if you're telling someone they need a big surgery, that is great impetus to stop smoking. That's way more power than I have just counseling someone about the benefits of smoking cessation. Alcohol, little more nebulous. Intensive interventions 4 to 6 weeks before a surgery lowers postoperative complications, but doesn't change length of stay or mortality. Very few studies, because you have to do a fairly intense intervention, which is hard to pull off preoperatively. Even fewer studies on cocaine or heroin or chronic marijuana. We think that cocaine increases your postoperative vascular risks. That makes sense. And that cocaine cessation would therefore improve that. Heroin and friends is usually a withdrawal issue more than anything else. And then chronic marijuana use, which is becoming more and more common, doesn't seem to change postoperative morbidity or mortality, but it does increase your risk of postoperative cardiac arrest. So cessation of that prior to surgery is probably a good idea. Then what does it look for in terms of functional support? Well, there's no data there, right? There's outside of multimodal frailty interventions, there are no studies on getting someone a social worker and improving their postoperative outcomes. But it makes logical sense that it would. And how do you do that? Befriend your social worker. There's the ADRC, the Association on Aging, home safety evaluations, Meals on Wheels. There's all sorts of things that they can help you do that they're far more expert at. So that's a lot, right? That's a lot for a pre-op clinic. And then we can talk about the practicalities. If we start stringing it all together, you have to ask yourself, do you have the time to really prehab this person and really pre-op this person? And if it's not you, who can do the screening for you, right? Because we're busy people, we got things to do. And how far before the surgery do you have to pre-op them for prehab, right? How many weeks does it take to make someone's post-operative outcomes better? How long does it take? 60 to 90 minutes. I can tell you that right off the bat. If you're really going to do a good pre-op evaluation, it takes an hour to an hour and a half. That's a long time. We learn to do things asynchronously in the clinics, and so it decreases the clinic time, and lots of screenings can be done by phone. You can use your multidisciplinary team to do so, but it's hard to coordinate. Realistically, here's a little model. So over the phone, your pharmacist can do the med rec, your MA can do a lot of the screenings, your social worker can do a lot of the screenings, then you can see them and do your medical bit, then the nurse can tell them how to do it. You can send them out for prehab referrals to physical therapy, and then they go to surgery. And then if you're feeling pretty wild, you can call ACE and have them do delirium prevention post-operatively, and then send them out to transitions of care. So that's a model. You can do that. It is complicated. It's hard to pull off. Conveniently for you, this is my moment of shameless self-plugging here, you have access to a geriatrician. We will do it for you. So we have what's called a POSH clinic, best acronym in medicine, perioperative optimization of senior health, POSH. We need at least 3 weeks lead time. So if you look at the data on POSH clinics work. POSH clinics decrease length of stay by 2 days. POSH clinics decrease all-cause mortality and morbidity by 30 to 50%. It takes 3 weeks at least to give you the prehab time we need to get them stronger and improve their post-operative outcomes. If you're not here or Duke or UT Southwestern, if you're practicing somewhere else, you need a PMR consult or a geriatric consult. But you can send them to POSH, and we will take care of this for you. So in wrap up, normal aging increases your perioperative risk. Frailty makes that worse. Geriatric pre-op is comprehensive. We will quantify the risk for you. We can mitigate some of that risk. It's a team-based approach, and it's complicated. And that is why grandma is still frail, but not that frail. So thank you. Questions?
This was really great. I'll open it up here to questions from the audience.
Hi, this is Ahmed Al-Niami. I don't know if you can hear me, but I will go ahead and start talking. Yep. Dr. Eastman, thank you so much for the talk. It's wonderful always to collaborate and have you see patients. In a more pragmatic question about the big picture, we deal a lot with elderly patients who, some of them are so frail that they cannot even make it to the clinic. And if they do, you sit down and talk with the patients and say to yourself, why such a frail person, that frail, is having colonoscopy, mammograms, and an ultrasound to be sent for a 5-centimeter simple cyst that seems to be there for 5 years. I think my specific question is, in a big picture, as a community, as a country, when do we say that there is so much frailty in that person that we really have to think about, kind of like stopping the active care, I call it, and really get those people to, quality of life care? When do you see, for example, a frail person that is absolutely cannot be salvaged? And so you question, like, why do we even do surveillance and see them in patients? I mean, I saw a patient that frail, and she's asking me about the 5-centimeter cyst. Actually, her granddaughter is asking me about that, and they were questioning me whether they have to go ahead and do the colonoscopy next week. And And what about the pap smears and everything? And I was just like, reached a point where, I said, you have to go and speak with your primary care physician about like the utility of this. So is there any big movements in the nation to put frailty in the geriatric population to be a triaging tools for further interventions?
Yeah, that's an excellent question, and you're right. There is a movement, kind of amongst those of us who do the geriatric pre-op world in our little POSH consortium. It's a slow moving process because it's not a sexy cause, right? It doesn't get a lot of grant money, and older people tend to be left out of the conversations. They're certainly left out of the studies, right? Most studies cut off at 70, 75, something like that. So it is a growing field. Part of it, cynically, is a payment structure issue because those conversations take a lot of time, and time is not valued nearly as much as other things in the medical world. So yes, those are conversations that should happen and don't happen often enough. Lowest age for referral to POSH really fast, 60. And I do make recommendations for, we will do any semi-elective surgery, and we have done POSH clinics for people doing their neoadjuvant chemo to try and get them to a Whipple. So that's like 9 months now. So yeah, never too soon. We will POSH anybody, basically.
Yeah. Thank you. Thank you for your hard work and good work.
Thanks.
I had a question. My name is Ryan Lowell. It's one of the generalists. Anyways, as far as using like for supplements for patients, what is your thoughts on collagen as a protein replacement? And I guess your thoughts on it in general.
Yeah, interestingly enough, it's sort of like one of those weird historical things where it cycles back through. Collagen is essentially Jell-O, right? And Jell-O was invented years and years ago as a prehab invalid supplement, and that was why it was always savory. So that all those horrible aspic recipes from old cookbooks all started off as health foods. The data is very squirrely. I think the best data is actually in sports medicine, which I'm not really a part of, about preventing injuries in young high performance athletes on collagen supplements. I have old patients who swear by it for their osteoarthritis. They take their supplements every day. They think it's great for their bones and their joints. Sure, the data is very nebulous. Not going to hurt them. I usually recommend that they just get a giant powder jar of like Knox gelatin powder and not buy expensive collagen supplements. But I think the jury's out. I think there's a hand up. Is there a hand up in the auditorium? I have a hard time seeing.
Yes.
Yes. Okay.
Thank you so much for that great presentation, Dr. Eastman. This is India, one of the third-year residents. I have a question similar to what Dr. Brown was asking. You mentioned that, for these patients to be properly, seen and managed in the POSH clinic, the ask is that they're being seen or being referred at least 3 weeks prior to their surgery. I'm wondering, what is the turnaround time for these patients to like actually get into this clinic? So say if their surgery is in 3 weeks and I put that referral in that day, like, is there a likelihood that they'll be seen, or do we need to be thinking about putting these referrals in many weeks before that to ensure that they actually get a visit 3 weeks before their surgery?
That is an amazingly good question. So we have been running this surgical pilot with surg-onc and colorectal and a little bit of gyn-onc now and again. All of those surgeries tend to be a little more urgent since 2019, barring a pandemic break. And so that's a relatively small group. So we've had capacity. So as of this week, the turnaround time is 11 days to get someone into a POSH clinic. If suddenly we get like 100 Urogyn referrals, that may require us to renegotiate our capacity and work on that. We have the model down to an NP-led clinic, which makes it a lot easier to switch around and clarify with MD backup. So that helps. the long and short of it is right now it's 11 days. If we're flooded, it's going to be like 3-4 weeks probably. If that starts happening, I'm going to change the way the clinics are structured so that we can increase capacity.
Thank you.
All right, well, it's time for us to wrap up. So thank you so much. This was really fantastic and tons of really great information. So thank you so much for coming and presenting for us today. And I'm sure if there are more questions, it's okay for us to email you.
I'm only ever an email away. Thank you guys so much. This was great.
Thanks. Have a good day, everyone.